Alright guys, let's get busy talking about male reproductive anatomy. We're going to start by talking about our organs, and we're going to take an embryological approach to this. So you guys will remember we have our testes, which are going to be formed from our gonadal ridge, and our testes are here, and they're going to contain our seminiferous tubules. And I'm highlighting this in brown because they're coming from the gonadal ridge. Moving on, we're going to talk about all of the structures that come from our mesonephric ducts. I'm going to highlight all of these in orange for you. So remember, our mnemonic for the mesonephric duct structures is seed. So we're going to go ahead and start with our seminal vesicles, which I'm going to label up here, and they are responsible for producing a lot of the content of semen. Specifically, they are going to make alkaline material that is going to help sperm survive in the vagina. Next, let's talk about our epididymis down here, and that's this little guy that's hanging out on top of our testes, and this is going to be the site that is responsible for sperm maturation. So sperm leave our seminal tubules and they go up into the epididymis and hang out for a while and get nice and mature. This is where they achieve their ability to become motile, etc., etc. Next, let's talk about our ejaculatory duct. This is the next E in seed, and our ejaculatory duct is going to be this portion right here, and it is where the semen and the urine begin to mix, and this is going to occur in the area of the prostatic urethra, which we will talk a little bit more in a bit. And lastly, the last thing in our seed mnemonic is going to be our ductus or vas deferens, and that's going to be this section here, which I'm highlighting in orange, and this is going to connect the epididymis, where the sperm mature, to the seminal vesicles, where they're ready to go on their journey out into the world. So let's move on to talking about our prostate gland, which is going to be this that I'm highlighting here in blue. And the prostate gland is going to have two portions. It's going to have an anterior portion, which is going to be where we get benign prostate hyperplasia occurring, and it's going to have a posterior portion, which is quite glandular. It provides a lot of secretions necessary for proper semen and also helps with lubricating the urethra. And this posterior section is going to be more prone to cancer. So it's important to know on test day the difference between what happens in the anterior and posterior regions of the prostate. Let's wrap up by talking about the penis, which is going to be highlighted down here in red. And I want to talk about various portions of the penis. Remember that the penis comes from the genital tubercle, and here in the pink area that I'm outlining here on the lateral sides, this is going to make the corpus cavernosum. And then in this orange portion that I'm highlighting, this is going to be the corpus spongiosum, and it's going to be the urethra that runs through the center of this corpus spongiosum. So let's imagine if we were to take a cross section here of our penis along its shaft, what would it look like? And if we zoom in here to get a better look at this cross section here, we're going to see we have the corpus cavernosum, which was our pink structure, and then we're going to have our orange corpus spongiosum with our urethra running through the middle. And additionally, there's going to be some important fascial structures which will relate to some pathology we discuss in a bit. So here around the penis proper, we have Buck's fascia, and then a little further out, we have Dartos fascia. And Dartos fascia is going to wrap around both the penis and the scrotum, so hold this into your mind because I want you to think about it later on when we talk about some pathology. So let's go ahead and zoom back out, and let's move our discussion to talking about parts of the urethra. So let's start out with the prostatic urethra, which we're going to highlight in blue. So it's going to run down here through the middle of the urethra, and the prostatic urethra is the portion where our semen and our urine are going to combine and go through the urethra and out into the environment. Our next part of our urethra is going to be the membranous urethra, and it's this little part right here, and it happens to be the thinnest part of the urethra, so it's going to be really prone to injury when we are catheterizing patients. And this happens to be where there's like a nice little bend in the tissue of the penis, and so if you like jam something in there really fast, it's going to damage that membranous urethra. Moving on in green, we're going to talk about the bulbar urethra, and that's this beginning portion of the urethra here in the penis, and this is going to be prone to a type of injury as well that we're going to discuss later, so keep an eye out for that. And finally, this last part of the urethra is going to be the penile urethra, which I'm highlighting here in red, and this is the last part of the urethra as it exits out into the environment. This is where we're going to be able to see the urethral meatus, which is this tip part of the urethra, and sometimes we can see blood or discharge coming from that area, and so it's an important one. Let's do a quick review of the structures we talked about and where they come from. So our testes are coming from our gonadal ridge, and then we have our seed structures, our seminal vesicle, ejaculatory duct, epididymis, and ductus deferens coming from our Wolffian or mesonephric duct. And then we talked about the prostate, which comes from the urogenital sinus. And finally, we have our penis, which is going to be a combination of our urogenital fold and our genital genital tubercle. Before we move on, I want to talk about the pathway of both semen and the pathway of urine. So in our pathway of urine, we're going to be tracing along the urethra, so prostatic, membranous, bulbar, and penile. Whereas in the case of our semen is going to take the path out of a mnemonic called 7-up. So 7-up is going to stand for seminiferous tubules, epididymis, vas deferens, ejaculatory duct. N stands for nothing, so I just put a little smiley face there, and then U is our urethra, and P is going to be our penis. So if we follow this path, we're here in our seminiferous tubules, we go up here to the epididymis, and then we're going to come down to the vas deferens, which goes all the way up, and it's going to go through our ejaculatory duct, and then it's going to come down here through the urethra and exit out at the tip of the penis. Now urine, on the other hand, is going to come from the bladder up here and down the urethra, and remember, we're going to have combination of this in the prostatic urethra, and that's going to be key, an area of mixing point. I like to think of the prostate as a big mixing bowl for all of our substances on their way out the penis. Let's move on now to talk about blood flow of our male reproductive anatomy. So here we have our big aorta and our big inferior vena cava. Let's talk about arterial supply first. So arterial supply to the testes is going to occur from our testicular arteries, which are going to branch directly off the aorta and go to the right and left testicle. Now when we talk about venous supply, this is where it gets a little bit tricky. So here's our inferior vena cava, and you'll notice we have our right renal vein serving the right kidney and our left renal vein, which is going to serve the left kidney. Now you'll notice something different here. Look at this right gonadal vein. It's coming directly off the inferior vena cava, and you'll notice that this left gonadal vein is coming off the left renal vein. So it's coming off of a renal vein, whereas this one's coming off the vena cava. That's kind of different, and it's actually quite important. And so you'll notice here that we have our left renal vein that comes all the way across the aorta, and it has to slip under this superior mesenteric artery. This is a really convoluted path, and so I want to talk about something called nutcracker syndrome, which is all about this superior mesenteric artery. Now you may be seeing these smiley face guys and being like, Jake, why are you drawing smiley faces all over this video? And these smiley faces represent fat pads, and these fat pads normally hold up our superior mesenteric artery, and it allows this left renal vein to course under there rather uninhibited. However, in the case of cancer or severe weight loss, these fat pads can get displaced. So let's imagine we had a malignancy that's coming in here and being really mean, and it's kind of disrupting this architecture of the fat pad. That could make it go away. Or if someone has severe massive weight loss, like they got a gastric bypass or some sort of weight loss surgery, they can rapidly lose these fat pads, and then our superior mesenteric artery is going to fall down, and it's going to trap this left renal vein. And so what happens in this case is this kidney is going to be really backed up. It's not going to be able to get its blood back to the inferior vena cava, and so you're going to see things like hydronephrosis and kidney failure, maybe some hematuria. But additionally, we're going to have some things going on with the left gonadal vein. Specifically, we're going to get a pathology that is called varicocele, and this is going to be described like a sack of worms within the scrotum. And this is because we have massive backflow of blood. So remember, we have a backflow here, and it's going to push back here, but it's also pushing down the left gonadal vein. And so you're going to get a bunch of blood trapped down here in the scrotum, and it's going to present classically like a bag or a sack of worms. That's how they love to talk about this on test day. And it's usually going to be a guy who comes in, he's like, hey, I have this weird sack of worms in my scrotum, and that's something they like to ask about. And then also they like to say that the varicocele is going to cause infertility because we have all that extra blood in our scrotum, and that really heats up the scrotum, makes it warm, and we know that our sperm maturation is temperature dependent, and so our Leydig cells, our Sertoli cells, are not going to like those high temperatures, and so that's another thing that they like to ask in terms of third order questions here. Let's zoom out now and review our blood flow. So we're going to have our testicular artery that comes off the branch of the abdominal aorta. It's going to come off the abdominal aorta on both the right and the left side. And additionally, we're going to have some other portions of our male reproductive anatomy supplied by the internal iliac branches. However, these are low yield, so we don't need to go into the specifics of them. What we do need to talk about specifically is the venous supply, right? So we talked about the fact that the left renal vein can become trapped, and that's going to cause backward blood flow and lead to things like varicocele or hematuria and kidney failure and things like that. flat. So that's going to be all due to our backward blood flow, and this is largely going to occur primarily on the left side in vignettes because that right side comes directly into the inferior vena cava, whereas the left side has a more convoluted path through the left renal vein. And remember, we like to call this nutcracker syndrome, and in terms of symptoms, left varicocele, hematuria, flank pain, and our causes are going to be things like renal cell carcinoma or intense weight loss, and we talked about that with our fat loss guys. And then there are also going to be a pampiniform plexus, which is a venous plexus that has like lacy reticular veins all throughout the pelvic plexus that's going to allow blood flow back up into the inferior vena cava as well. Let's move on now to talk about some lymphatic drainage. This is rather high yield on the exam. They love to ask about this, and this is due to embryology. So we know that our testicles are going to be a retroperitoneal structure, and so they're going to be quite deep, and their lymphatic supply also follows their path down from the retroperitoneum down into the scrotum. So in terms of the testes, it's going to be our para-aortic nodes that are going to supply the testes, and I put these in our drawing here, right along here, which I'm highlighting in green. So these nodes are right along the aorta, and this is what needs to be biopsied if we're like suspecting a testicular cancer or something of the sort. We also have some other lymphatic drainage from our scrotum. I'm drawing it in this like light green color because I consider light green like a superficial light color. So we have superficial inguinal nodes to our scrotum because the scrotum is really superficial structure. And I'm going to use this darker green color to talk about the prostate and the corpus cavernosum, which are going to drain to our internal iliac nodes, which makes sense because they're internal structures, so they're going to drain to an internal node. That's why I'm using this dark, deep green internally. Let's move on now to talking about this sexual response, which is going to be how males develop erections and eventually ejaculate in the act of intercourse. And don't worry, I kind of reset some of our colors here in our diagram, but that's just so we can get a better look at some of these structures that are coming up. So let's go ahead and get started on the sexual response by talking about a mnemonic, and the mnemonic here is point, squeeze, and shoot. So let's walk through this mnemonic, starting with erection. It's going to be all about pelvic parasympathetic nerves, and you're going to see here that I have this highlighted in orange, and so that is the point portion of our mnemonic. And it's important to also note that during the erection period, this is going to be due to blood flow that's going to be filling the corpus cavernosum, and some drugs that we talk about in relation to treating erectile dysfunction are going to be PDE5 inhibitors such as sildenafil, so that's something to be aware of in relation to erectile dysfunction. So let's move on now to talk about squeeze, and squeeze is going to be all about emission. So remember when we followed our blue path of sperm all the way here, this is the squeeze portion. It's getting that sperm up and down to the prostate and into the urethra, and this is going to be due to the hypogastric nerves, which are sympathetic in origin. And then finally we're going to have shoot, and shoot is going to be due to pudendal nerves, which are going to be somatic, and this is actually going to be clenching down to force that semen out into the environment in order to facilitate reproduction. Let's move on now to talk about our urethral injuries. We're going to have two types of urethral injuries. We're going to talk about anterior first and posterior second, but let's quickly do a review of our urethra because it has a lot of parts. So remember, we have our blue prostatic urethra, which is here. We have our pink part, which is the smallest and narrowest part, which is our membranous, and then we have our green bulbar urethra, and then our red penile urethra. So after that quick review, let's go ahead and get into our anterior urethral injuries, which are going to be due to damage to the bulbar urethra, which remember here is this green portion that we just talked about, and this is going to be most common in straddle injuries. So you're going to think of like a skateboarder who's like trying to do a mad trick and he like straddles his legs over like a bar. That is the classic person who's going to get this type of injury. And our presentation here is going to be blood at the urethral meatus as well as a scrotal hematoma, and let's talk about more about how this happens by looking at our little cross section here of our penis. So you'll notice here that here's our cavernosal artery. It is what supplies blood to our penis, and then we have our urethra, which is covered by our corpus spongiosum. And essentially what happens here is we get trauma here, and then when it comes to blood from that trauma, that blood is going to start leaking out and filling up this penile cavity, and then this penile cavity is lined by Buck's fascia. And so what happens is if we get a rip in Buck's flux fascia from this traumatic injury, which is what happens, then this blood is going to leak out, and it's going to leak out into this area here. And what happens is that this area is confined by dartos fascia, and dartos fascia is actually going to go all the way down to the testicles, which I'm like kind of labeling here off to the side, and the scrotum. And so that's why we get a scrotal hematoma, because it's dartos fascia that is holding all this blood and kind of channeling it down towards the scrotum, which is why this anterior urethral injury bleeding leads to scrotal hematoma. Zooming out now, let's talk about our posterior urethral injury, and this is going to be damage to the membranous urethra. And let's refresh ourselves. Our membranous urethra is this really thin part here that is really, really small. And so you're asking like, okay, that looks like it's a pretty deep structure. Like, how are you going to damage that guy? And the answer here is going to be pelvic fractures. So when we have people in like motor vehicle accidents or other really traumatic events that can cause a pelvic fracture, and you're noticing blood at the urethral meatus, then you're going to be like, I think this is a posterior urethral injury. And there's going to be another thing that we can see, a high riding prostate. I don't know who would actually do a prostate exam on someone with a urethral injury. It seems so painful. But if you indeed did try to do this, then you would see that the prostate here is actually going to be riding up higher in the pelvic cavity. And this is because there's a lot of blood that is accumulating here, and it is pushing the prostate up, up, up. I'm not sure how you would be able to differentiate this from a normal prostate exam if you never had a baseline for this patient, but I digress. It is interesting, and they love to ask about these interesting weird things on step 1 like this. So be looking for that high riding prostate, and that is going to be due to the fluid leak, aka blood, into the retropubic space. And so let's take a look at a cool image here. If we zoom in, we're going to see this is a retrourethrogram, and so let's follow the path of this fluid. To orient ourselves here, our tip of the penis is going to be right here, and they're going to be pushing in a dye that is going to be traceable, and you'll see this dye has a nice smooth margins all the way up until we get to this area here, which would be delineated by our membranous urethra, and this is where we start to get this jagged appearance here, and then we get much less dye that is flowing further up towards the bladder. And so we know that this dye is likely leaking out into this space, and that's why we're going to get things like a high riding prostate from urine and blood leaking out into that retropubic space. In terms of a high yield review, I would really focus on knowing the parts of the urethra. I think people sleep on this part of the exam, and it can really get you a lot of points because they love to ask about it. And then also having 7-Up in your back pocket so you know the pathway of sperm. And then so high yield is going to be our nutcracker syndrome. And remember, vignettes are going to usually present with someone who has evidence of massive weight loss or perhaps a malignancy, and that this is going to be due to the differential anatomy on the right and left side, and that this will eventually present as varicocele or kidney damage. Moving on to our lymphatics, we talked about the para-aortic nodes being high yield for that embryologic descent from the retroperitoneal space into the scrotum. And then our sexual response, we talked about point, squeeze, and shoot being parasympathetic, sympathetic, and somatic. And then we talked about the difference between our anterior urethral injuries and our posterior urethral injuries, and that's going to be all about knowing your parts of the urethra and how they are going to present on exam day.